Hey everybody, this is Angela Dupuy and Sarah Hopkins for Advanced Pharmacotherapeutics, summer of 2019. We're going to take a look at a case for a gentleman regarding chronic opioid use for his back pain. So a little background, we have Marv Wilson, who's a 40-year-old male who has been working in construction since the age of 17, currently taking oxycodone 30 milligrams 4 times daily for chronic back pain caused by spondylosis and is resulting in radiculopathy. So vital signs here in the office: 98.4, 88, 17, 132 over 84, 98% on room air. He's 5'7" and 200 pounds with a BMI of 31.3 in the obese category. Past medical history: hyperlipidemia, obesity, spondylosis, chronic pain, constipation, OSA, and depression. So medication list: atorvastatin 20 milligrams daily, ibuprofen 600 milligrams 4 times daily, sertraline 25 milligrams daily. He uses icy hot, lidocaine 5%, topical patch daily as needed, and the oxy again. Colace 100 milligrams twice daily, bisacodyl 10 milligrams approximately every 3 days, oral, and Senna 8.6 milligrams at bedtime. So history of present illness: he was a foreman laborer, but due to his back pain, he transitioned to operating the excavator. This was helpful for about a year, where he only required oxycodone twice daily after working hours. About 6 months ago, his back pain became so severe that he required a dose increase from twice daily to 3 times daily. A few months later, pain again was poorly managed and oxy was increased to 4 times daily. So can't be operating heavy machinery on oxy 4 times a day, unfortunately. So he presents today in the office stating, "I need to return to work, but because I operate heavy machinery, I need to pass a drug test and can't take this oxy anymore. Doesn't work that great anyway. Can you give me something else?" So at time of visit, his pain is a 7. His self-identified threshold is not yet established, and his last dose of oxy was 2 hours ago, meaning that that oxy is not really bringing him down to a good pain level. All right, so for assessment and review of symptoms, just in the interest of time, we'll go through the highlighted things here, sort of the more abnormals. Marv reports that overall his mood is not too down, but does have low energy. Blood pressure times 2 visits has been slightly elevated, so something that we definitely want to look at here in this visit, and part of our treatment plan can certainly address that. GI, constipation, again, a presumable side effect of the oxycodone. He's taking the laxatives for that. Gradual 35-pound weight gain over the past 2 years, which is probably both causing and contributing to what's going on with him. So for neuro, he endorses a sharp pinching sensation that radiates down the left leg, worse with prolonged sitting or standing. Musculoskeletal, his mobility is limited, gait steady but slow and stiff. And again, pretty classic that his pain is worse with prolonged sitting or standing. So it's pretty clear here, Marv is stating that his goal is to discontinue the use of oxycodone with the purpose of returning to work. He meets the following criteria for dose reduction or discontinuation per the CDC, which has some great resources on opiate dose reduction. So he triggers for the 3 following criteria. He's requesting a dose reduction. He does not have clinically meaningful improvement in his pain and function, and he is on doses greater than 50 MMEs per day without benefits from the opioids. So that's morphine milligram equivalents. So he's, stating that it's not working that great anyway. So those 3 things are 3 great reasons to sort of bring him off of this medication. And then what about his SIT, that self-identified threshold? I know a lot of folks use some version of this in their practice. It's called a few different things. In hospice where I work, we use the self-identified threshold, which is basically where the patient is really saying what their, comfortable level, or, what a level of pain that they can function with and consider it tolerable. So really important to establish that as we start this journey with Marv. So he's stating that his pain used to bring him down to a 3 or 4 when it was most effective, and he feels like he would be able to manage his daily life at a level of a 3. So we would put his SIT at a level 3 as our sort of goal here. And at present, oxycodone brings his pain down as low as a 5 or a 6, and he can get as high as an 8 or a 9. So definitely a lot left to be desired here with his pain management. So the CDC tapering guidelines, again, had some great resources that we really, use that as our standard here for what we're going to work with Marv on. And they recommend a dose reduction of 10% per week in patients who have been taking opioids for a longer period of time. It may be as gradual as 10% per month. So really it's a very individualized approach that's going to help guide the rate. We'll certainly start with the 10% per week, see how that goes. And if he's tolerating that well, we can certainly continue that or speed it up depending on his comfort level. And then also the withdrawal symptoms, that certainly can play a pretty big role in how quickly we're able to reduce his dose. So he's been taking opioids for the past 14 months with 120 milligrams per day for the past 3 months. So a pretty hefty dose. And given his long-term high dose of opioids, he's going to demonstrate physical tolerance and dependence here. And because of his history of depression, we definitely want to consider the potential for psychological dependence. That could be a barrier to successful tapering as well. Just as a side note, in our office here, Marv, as a little side note, just thinking about insurance, that he does have great insurance. His wife still works for the city, so he's endorsing having a health insurance plan that has always taken good care of him. So good for Marv. Currently, he's accessing his long-term disability benefit through his work, but obviously that's not going to carry on forever. So time may be a factor here as well, playing into our treatment plan as we move forward through things. So for week 1 here, we can't really project what we're going to do too far out because, again, it's going to be individualized based on his tolerance. But at 120 milligrams of oxycodone a day, we're going to recommend the initial slow taper in the first week or 2. So we'll do oxycodone, keeping the 30 milligrams for 3 doses out of his day, and then at bedtime, knocking it down to 20 milligrams at bedtime. So adding a little clonidine at 0.1 milligrams twice daily for the withdrawal symptoms. It's also going to have an effect on his blood pressure, but it's not too soft lately, so not too worried about drastic hypotension given the low dose, but something we'll talk about monitoring. Neurontin is something to consider adding in as well to manage the type of pain that he's specifically struggling with. And then we would want to look at backing off on that ibuprofen that he's been taking as well. A maximum of 400 milligrams every 6 hours as needed, but should not be taken daily for greater than 30 days due to the increased risk of cardiothrombotic events, GI bleed, ulceration, or perforation. So some education to be provided there. The clonidine, we can talk about increasing that as well to manage his withdrawal symptoms or minimize them as much as possible. And that can be titrated up at 0.1 milligrams per day at weekly intervals. So the max dose for that is 2.4 milligrams per day. For withdrawal symptom management, we're usually looking at a typical range of 0.2 to 0.6 milligrams per day. So just a little information on So week 2, then we're going to reduce again one more dose out of his day. So he'll have 2 doses at 30 milligrams a day and 2 doses at 20 milligrams a day. We'll want to alternate those, and then we can increase his Neurontin as well to get that to help his pain and manage that during this taper. And then again, we can continue to titrate up on the clonidine depending on how his withdrawal symptoms are or how severe they are. Again, we'll want to see him in the office for a follow-up and monitor him closely, assessing his pain, his withdrawal symptoms, mental health status. We could consider, remaining at that 10% dose reduction, or we can, speed it up a little bit if that is possible. It's going to take a while to get him to not just a reduced dose to where he was 6 months ago, but to just get it off. We're probably looking at months and months here. So it's a long journey. And a lot of offices utilize the COW score to gather additional data on withdrawal symptoms, appropriateness of treatment, and managing the schedule that we're going to be setting for him. And during the process, if his pain is persisting above his sit, then we can consider increasing the Neurontin further. There's a lot of room there for that. Or we can consider adding another medication such as tramadol or Ultram as an additional alternative therapy for managing his pain. The Ultram is considered in the opiate family, so it's not something that we would necessarily want to go with first, but if the pain is one of the biggest barriers to reducing the oxycodone dose, then it's an acceptable alternative to add in there. So some ADRs we want to keep in the back of our mind. Oxycodone, we know those opiates have a whole host of side effects, including constipation, sedation, risk of injury. Hopefully, as we reduce those doses, those side effects will be reduced as well. The senacolace and bisacodyl, again, as we reduce his oxycodone dosing, he may need less of those, so monitoring for changes in his bowel habits and adjusting those accordingly, hopefully in the reduction as well. For the clonidine, again, we're probably going to see a little reduction in his blood pressure while we add this, and that is welcomed where his blood pressure has been elevated for the last couple of visits. So certainly something that we would want to consider a home self-monitoring for. We don't want him to dip down too low. And this medication can have increased effects with alcohol. So in addition to having a little bit of a reduction of his blood pressure, if you put some alcohol on top of that, he could dip down pretty low. Can also cause sedation, especially in combination with the oxycodone. Neurontin, adding this as a long-term pain management medication, that's going to depend on how he reacts to it. Some folks can have mental status changes and mood changes. For him, that may not be a side effect, and it could be something he can continue when he returns to work. But this taper is going to take months anyway, so something that we will be able to address with him as things unfold and as we titrate the Neurontin dose, if it is even effective at managing his pain. So setting him up for success, education is going to be, I think, a huge component here that we want to work with him on. The CDC had a couple of thoughts on providing some, positive support that, we know you can do this. We're going to stick with you through this. Call us if things aren't going well. There are a lot of things that we can do. This is just a jumping off point. There's a lot of flexibility here. That sort of language can be helpful in keeping the door open for this patient to hopefully have an open dialogue about what they're going through and how we can best support them. Education about how most folks end up having improved function without worse pain after tapering their opioids. Can be a nice little incentive for them. Also, some patients have improved pain after the taper, even if the pain briefly gets worse at first. So, we certainly don't want to make this sound like an easy road, but that a lot of folks, after they're able to get through a taper, even if it is difficult, can really, we can have a different plan that can even be better for them. So we want to definitely emphasize the importance of a multidisciplinary approach, that there are a lot of different things that we can do to help support him and manage his pain. Really important to not reverse the taper. If withdrawal symptoms or pain are intolerable, we want him to be calling the office, not to just reverse his taper and go back to the dosing that he was on. We don't want to 2 steps forward, 1 step back here. We want to keep that momentum going. Weight loss for Marv really might be the single best thing that he can do for his health right now. It's going to address a lot of his issues, including his back pain, his obstructive sleep apnea, blood pressure. Again, the clonidine will also affect this probably, so something we'll need to monitor, and then mood and energy. So we may want to, as one of our top referrals for Marv, connect him with a dietitian or a structured weight loss program to help sort of jumpstart. If he's not, feeling great with withdrawal symptoms, that, might not be top on his priority list, but, we want to certainly emphasize the impact on his quality of life. So again, setting him up for success. We want to consider integrating some or a combination of the following into his treatment plan. So for managing his pain, definitely the acupuncture could be helpful. The back pain, nerve pain also could help address depression and constipation. That is often used alongside chiropractic care. Could definitely address the radiculopathy. Physical therapy, will also help his back pain by focusing on strengthening and mobility, which will improve, his overall, hopefully function, as well as weight loss. If he can move more, then he can be more active, potentially, have some more weight loss, which could have a positive impact on his back pain. A mental health referral certainly might be helpful as well, just to, manage some of the difficult barriers that he's going to come across over the next several months as he tapers down his dosing. So definitely a lot at work here. This is really just a jumping off point for him. Things can definitely get much more complicated as patients get into this taper, needing a lot of management, but we'll start here and see where he ends up. Some references here that we have to be familiar with. The CDC had some great information, and then a couple of other references that we used that had some great information on supervised opioid withdrawal during treatment for addiction or dependence. Any questions? I guess you can message us, and hopefully this was helpful at understanding how this process might start off. Have a great day.